Hello. So I'll be talking about radioactive iodine. Before that, I'll just talk a little bit about thyroid. So if you consider this as the thyroid gland, this is the pituitary. Pituitary releases thyroid stimulating hormone which acts on the thyroid follicular cells. These are the cuboidal follicular cells, which with the help of iodine releases thyroid hormones such as T3, T4, which again acts negatively, inhibits the pituitary to release TSH. This is that negative feedback loop. These are the follicular cells, these are the parafollicular cells. Now, the tumors arising from the follicular cells or papillary and follicular thyroid carcinomas, and the tumors from the parafollicular cells is the medullary thyroid carcinoma, and there is also anaplastic thyroid carcinoma. So, just briefly telling that papillary carcinoma is the most common one, and Hurthel cell is a variant of follicular carcinoma. Medullary carcinoma is associated with increased calcitonin because the C cells, which are the parafollicular cells, secrete calcitonin, and the collection amyloids are also seen in medullary. And anaplastic is a very aggressive cancer. It is seen mostly in older or elder patients. It has very poor prognosis because less than 5% survive 5 years. And medullary is associated with men 2 syndrome. Papillary is associated with Gardner, Tauchoids, and familial polyposis. Follicular is associated with Counden syndrome. And orphan Annie eye is a feature of papillary. And one important thing about the follicular one, it is difficult to differentiate on FNSC whether it is follicular adenoma or carcinoma. You need the whole thyroid gland for it to differentiate, so you cannot differentiate on FNSC. So basic about the management also. So the main management is surgery, that is hemithyroidectomy or total thyroidectomy. With hemithyroidectomy, a follow-up is difficult because thyroglobulin will be there and residual thyroid gland will be there, so it will show uptake. So hemithyroidectomy is not a preferred one, so total thyroidectomy is preferred. But with total thyroidectomy, since the whole thyroid is removed, you have to give long-term thyroxine, that is levothyroxine, and you have to keep the TSH suppressed. So TSH, you have to keep it suppressed so as to decrease the recurrences of the thyroid cancer. Now about the adjuvant radiation, in which cases will you, not adjuvant treatment, not adjuvant radiation, adjuvant treatment with the TSH to be suppressed, radioactive iodine to be given, or EBRT, that has their own indications. The most common indications are if the tumor size is more than 4 centimeter, if there is extrathyroid extension, post-op unstimulated thyroglobulin, aggressive histology, these histologies, and in those cases adjuvant treatment is indicated with the thyroid TSH suppression, iodine 131 plus or minus EBRT. Now for EBRT, it has its own indication. I'll be mostly talking about the RAI, that is radioactive iodine. So we have iodine 131. Iodine 131 is actually given. It has oral. It is in the form of oral tablets or oral solution, and its T half is 8 days. And mechanism of action, it is producing beta particles. These beta particles accumulate in the follicular cells, and these follicular cells here the iodine produces those beta particles, they are thereby destroying this thyroid tissue. So mechanism of action is by the production of the beta particles. Now indication is ablation of the thyroid tissue, the remnant thyroid tissue or remnant thyroid normal tissue, which is remnant, that you have to ablate within 4 weeks after the total thyroidectomy. And other indications are adjuvant treatment, metastatic cases, and recurrent cases. The dose which is given in ablative is 30 to 50 millicurie, and 100 to 150 is for adjuvant, and metastatic is 150 to 200 millicurie. Now how do you prepare the patient for radioactive iodine therapy is like you tell the patient to avoid breastfeeding. If the patient is breastfeeding, to avoid breastfeeding by 8 weeks, at least 8 weeks before planning RAI. Low iodine diet should be taken. They have to avoid seafood, they have to avoid any iodine IV contrast as well, they have to avoid amiodarone as well. and they have to, if it's a male patient, then sperm banking because it can cause a zoospermia. And then the main point is preparation of the body for the TSH stimulation. Since post thyroidectomy, we would have put the patient on levothyroxine and everything. We have to do TSH simulation here because when we give radioactive iodine, if the TSH is raised, the thyroid the follicles will take up the iodine very readily. That's why we need TSH stimulation. Now, how do you do that? You can do that either by giving recombinant TSH, also called as thyrogen, or thyroid hormone withdrawal. You will withdraw the thyroid hormones T3, T4, so that thereby it anyway will increase the TSH hormone. So either recombinant or thyroid hormone withdrawal, but the most recommended one is recombinant TSH. So these are the preparation stage. So once you admit the patient, on day 1 you give thyrogen, that is recombinant TSH. Day 2 again thyrogen, so that the TSH remains stimulated. Then day 3 you give radioactive iodine. Day 5 you measure for TSH and thyroglobulin. Day 8 you will do the iodine scan or spectrum. So while the patient is admitted, you have to take care of the patient so that the patient avoids constipation. Constipation is avoided so as to decrease the bowel dose, because we are taking it orally. So orally, if it stays more in the bowel, it can increase the bowel dose. So drink a lot of fluids, suck candies, so that decrease the dose to the bladder or salivary gland, because these are the places which physiologically the iodine gets accumulated. So you physiological accumulation is there. So to avoid those things, because if radioactive iodine stays in those areas, there secondary malignancies can happen in these areas. Sialidinitis can happen because of the salivary gland, because of the iodine being remnant over there. And the patient has to be admitted for 2 to 4 days. The patient has to be isolated. He also has to have isolated toilets, isolated towels, and everything isolated. And radioactive protection wise, after the radioactive iodine therapy, the patient has to not undergo any blood or invasive procedures for a month. There has to be no close contacts either with a child or pregnant woman for at least 3 weeks. He has to double flush the toilet for at least a week after RAI procedure, and avoid, if it's a female pregnancy a patient, avoid pregnancy for 6 months. If a male patient, avoid fathering a child for at least 4 months. And if they get pregnant, there will be increased risk of miscarriage within 1 year. Side effects: acute or nausea, vomiting, gastritis, sialidinitis, neck swelling, xerostomia. Late is azoospermia, pulmonary fibrosis, chronic sialidinitis, and secondary malignancies.